Recording in progress.
Good evening, sir, and all respected doctors. On the behalf of Lupin Spiritus, I welcome to all doctors in our e-virtual platform, that is Pediatric ECME series, on the topic Back to School Pediatric Asthma Amidst Covid-19. So I welcome to our speaker, Dr. Dibyang Pathak, sir. Sir, we welcome you.
Yeah, hello. I am
So
Yank.
I just work at consultant in Medanta Hospital. Sir also have received several awards in international level conferences for his research and work study. Currently, sir is working as a director of Vatsal Multi-Specialty Children Hospital, Varanasi, which is a renowned hospital in our UP. So, not taking so much time, sir, I would like to hand over the session to you. Sir, over to you.
Hi, everyone. Good evening. So I'll be today. Is my topic is back to school from clinical consideration for children with pediatric asthma amidst the pandemic of COVID-19. So right now, I'm sorry for my voice because for past 2 days I'm also suffering from viral URTI. So I'm sorry for that. If I stop for some few seconds in between. So I am Dr. Divyank, as they have already given the intro. So we'll start with the topic back to school. Okay. So now COVID-19, we know that the timeline, it started from December 31, where China alerted WHO, which is also controversial. And it still continues to be the major problem in the all of the world and especially in our country also. Though right now we are recovering from most of the problems, but still the corona is not gone away. Maybe the elephant is out, but the tail is still stuck inside. I guess so. If third wave is not there. So, COVID-19 pandemic in India has caused us unprecedented level of devastation, leaving no sector, no aspect of our life untouched by its deadly consequences. Okay, just a second. Fine. So now during the second wave, we know that in the March and in April, India went in the most of time of managing COVID patients because of the so much of sudden resurgence of cases. The second wave had not been added, and that the leading expert of the nation sounded alarm bells for a possible third waves, and which is possible disproportionate impact on vulnerable groups like children. Now, these were the lines which was on news few 1 or 2 months back, that children will be very susceptible for the next few months, especially for the case of third wave. So, expert warned us that the third wave will be imminent, and it will cause maybe in the first week of May. Dr. Vijay Raghavan, Principal Scientific Advisor to PM, called the third wave to be inevitable, and could be the age, could cause all age groups, especially in the children, and because they are not vaccinated, and can be bigger than the second wave of previous wave also, but it can be very alarming. The government woke up and got healthcare set up ready in all the sectors and areas possible, and still we are getting ready about the third wave. So IIT Kanpur also predicted the three likely scenarios for the third wave. The one was back to normal to October, till October, which is right now. We are the way the things are going on. I think scenario one suits well right now, but the scenario two was emergence of new and more virulent waves in September, higher than second wave. It's proved to be wrong at present, but still these are not these are just some calculation and predictions. Still, there are a risk of third wave to be in next year or late in this year. Till we have a vaccination for children and all the children and all the population are not vaccinated and new virulent variant do not emerge, we still have the risk factors. And third scenario was strict intervention in late October, lower than second surge. So first surge back to normal, I'm not totally convinced we are not back to normal, at least. Third, very strict interventions was taken, and interventions we were in between 1 and 3. Many were not taking interventions, and many were taking. So at last, at present, we have a considerable lower amount of cases from the second surge, and still third surge we do not predict right now that it will increase it just in next 1 or 2 months. So COVID-19 is a very infectious disease, as we all know. It's caused by SARS-CoV-2 virus. It could be scary for everyone, but for the parents of those with asthma, now here come asthma, childhood asthma in COVID-19. We're going to talk. What about if asthma combines with COVID-19? So parent of those with asthma, there is a great fear that they might have worse outcome. Obviously, we as a common people or common man, layman will think that already the patient or the child is asthmatic, taking steroids and taking many medications, and on that COVID-19 comes and the child get infected from COVID-19. Obviously, the outcome will be very drastic, very sudden or very bad. The current clinical evidence suggests that the risk of severe COVID-19 may not be dramatically increased in those with asthma. So we need to know that if the person is having asthma and that person have COVID-19, then clinically till now, the evidence has suggested that it doesn't increase the risk of life severity till now. However, it is vital that the patient with asthma implement appropriate steps to make sure that asthma is under control to reduce the chance for more serious exacerbations. So obviously, this is a baseline thing. Whenever there is a patient of asthma, there has to be a control, because whenever there is no control, if the asthma exacerbation is there and patient is unstable, then the patient or the children are controlled with high dose of steroids also. So at that time, they become very vulnerable. So control of asthma is very, very important in be it COVID-19 or be it any other disease. So that is a very important point. So asthma and COVID-19, is there really an increased risk? Now, people with asthma do not appear to be at risk of acquiring COVID-19, and systemic reviews have not shown an increased risk of severe COVID-19 in people with asthma. So this was shocking when it got researched that the people with having severe COVID-19 and asthma did not appear to have increased risk of severe COVID-19. The people having asthma with COVID-19 did not appear to have severe COVID-19 risk factors. So that first line is very true. because systemic reviews have already reviewed it. Overall, the people with asthma are not at increased risk of COVID-19 related deaths, and however, the risk of COVID-19 death was increased for people who had recently needed oral corticosteroids for their asthma. Therefore, it is important to continue good asthma management with strategies to maintain good symptom control, reduce the risk of severe exacerbations, and minimize the need of oral corticosteroids. So, as we all know that whenever we have to control asthma, if asthma exacerbation is there, we need oral corticosteroids, and using oral corticosteroids will decrease the immunity and will open up the doors for other infections to harm you. So it is not new. So that applies same for COVID-19. But if we combine both, that the patient having underlying asthma genetic phenotype or risk, and a patient having COVID-19, if we combine both of these, then the risk of the patient going in severe COVID-19 or ARDS is reduced. Now, we'll see in mild COVID-19, there is early and effective interferon 1 response. And the viral load is initially higher and then it is lower. And COVID-19 course severity because of the hyperimmunity or hyper immune system, or because of the viral damage, there is a COVID-19 disease. Now in severe, there is excessive and protected interferon 1 response initially from day one. The viral load is there and it decreases, but the severity goes on increasing because of the inflammatory response of interferon 1. But when we combine in COVID-19 and asthma, as we know that asthma is under an umbrella of allergies, it's kind of allergy. Now, allergy is a Th2 kind type of immune system response. So, in Th2 response and the COVID-19, when we combined the pathophysiology, then we saw that there was reduced interferon 1 response due to Th2 dominance rather than Th1 dominance in normal people. As in asthma, there is Th2 response is dominant. So interferon 1 response was less. Thus, the course severity, as in severe COVID-19, we couldn't correlate that the course severity was not that much, which was expected that asthma patient can have increased risk, but the risk is same or lower. So it is a kind of good news for asthma patient that COVID-19 will might reduce the severity of COVID-19 for you. Now, COVID-19 and asthma. Now, what patient needs to know? Now, the myth that those with asthma will have a worse outcome. Fact, although the CDC states that the patient with moderate to severe asthma could be at great risk, there has not been any published data to support this, but there are reports, there are systemic reviews that the risk can be reduced if it is controlled. Those with asthma are more likely to get SARS-CoV-2 with the virus. To date, there is no evidence of increased infection rate in those with asthma. However, new information could change the situation, but till now, we have enough data, and right now, the risk have not increased. Now, steroids are not given to treat mild COVID-19 diseases. So, controller medications, inhaled or oral corticosteroids, may need to be discontinued. So, there is a therapy that, like in COVID-19, when the COVID-19 is severe, now then the patient needs to be given steroid. And what about the patient? Who don't need who are getting steroids? So they don't need to stop their steroid, because that steroids are acting at a different dose, different level, and for different purpose as to control asthma, and they are not acting in differently. So reports to this effect are related to the use of steroid to treat the virus itself. Use of steroid for asthma have not been studied. Okay, so do not stop asthma controller medicine. That is the main thing. Prevent, minimize your risk of an asthma exacerbation requiring an emergency department or urgent care visit, where the risk of exposure to COVID-19 is much higher. Okay, and prepare, keep your asthma under control to best prepare your lung should any infection or allergen may lead to an asthma exacerbation. Continue taking asthma control medicines. This is from an American Academy Allergy, Asthma and Immunology. They are recommended that. So this is very, very important. So asthma in the wake of COVID-19 in GINA now 2021, the guidelines, they advise that the patient with asthma to continue their prescribed asthma medications, particularly ICS, inhaled corticosteroids and oral corticosteroids if prescribed. Now, asthma medications should be continued, and stopping ICS often leads to potentially dangerous worsening of asthma. So you, in a nutshell, maintaining a good asthma control will also help limit outpatient clinic and emergency room exposure. So if you keep a good control on asthma, so that inhaled corticosteroids is not stopped, or you don't need oral corticosteroids, and you don't need to go to the hospital very more frequent. So obviously the risk will be decreased as exposure will be decreased as you don't go out. And as a biological therapy also, for the patient with severe asthma, continue the biological therapy and do not suddenly stop the steroids or do not suddenly stop the ICS or OCS. So that will again cause a sudden resurgence of asthma, and that will increase the risk of asthma because just by the fear of having COVID-19. Actually, but in reality, the COVID-19 and asthma are going side by side is better if you follow simply the asthma guidelines and asthma treatment. Do not worry about COVID-19, just follow the precautionary measures for COVID-19. So the make sure that all patients have a written asthma action plan with instructions. So many people follow an asthma action plan where there is a plan for whether the asthma is controlled or getting worse or it is severe. There is a sheet you give to the patient and they monitor it, and if they have any problem, they contact you. So maintaining a action plan or surveillance over the asthma patients is very helpful so that they can have a better control. Increasing controller and reliever medications when asthma worsens. Taking a short course of oral corticosteroid for severe asthma exacerbations. When to seek medical help, and see the GINA Guidelines 2020 report for more information about the treatment option for asthma action plans. So now basically, if whenever there is asthma, if it exacerbate, then do not hesitate to use oral corticosteroids. Do not hesitate to increase the controller and reliever medications. And if you fear that by increasing the steroids, COVID-19 may, if the COVID-19 is also there, and asthma patients are also coming, COVID-19 patients are also coming, then do not fear to increase the treatment of asthma at that time of at that point of time, because asthma needs to be controlled, and when asthma is controlled, there are sufficient evidence that COVID-19 and asthma goes well when they are hold hands each other. Now, COVID-19 vaccinations for children. So this is a very awaited topic and awaited thing for everyone in India. There are a few promising data set that experts are examining that includes the vaccine candidate for Zydus Cadila, tried above 1,000 children, and Bharat Biotech's co-vaccine trial is also going to be there. So they are at present in India. There are three vaccines have been going into the trial for basically for children. Co-vaccines, Covishield for more than 12, Covaxin for more than 2, and there is from Zydus Cadila for more than 6 years. At present, based on the benefits and risks, the above caution, GINA 2021 recommends a COVID-19 vaccination for people with asthma should be there. Now, the patient having asthma, not children's, all the patients of asthma can get COVID-19 vaccination, whether on controller therapies, whether on steroids. Okay, so don't get confused about these things. They should go and get vaccinated themselves, because most of them will not go in fear that they are at risk. They will not go, encourage them and go get them shot. Asthma in nice guidelines. Now there are other aspects. Now you tell your patients or their parent or caretaker to wash their hands and clean equipment such as face mask, mouthpiece, spacers, peak flow meter regularly using detergent or normal water liquid as instructed as per your pediatricians, or to follow the manufacturer cleaning instructions. So it has to be cleaned thoroughly. This has to be very in priority for COVID-19 preventions and other infections also, because right now other viral infections are also taking up, like influenza and RSV and adenovirus. So we have to take proper precautions which will take care of COVID-19 also. So asthma, regarding biological treatment, tell patients or their parents or caretaker that they should continue treatment, because there is no evidence that biological therapy for asthma suppress immunity. Biologics like omalizumab or other IL inhibitors, if they are on that, do not try to discontinue that, because it acts specifically at conspecific receptor that is very essential for control or on asthma. So biological treatment, biologics should not be stopped in fear of any COVID-19. If the patient usually attend hospital to have biologic treatment, think about if they can be trained to self-administer or could be treated at community clinic or at home. If you have a COVID center and you have the COVID-19 cases are increased at your place and there is increased risk of transmission at your place, then you can make your asthma patients train themselves or try to give biologics to those subcutaneous injections and any other places. You can train them so that they should not have more exposure. Now you can carry out routine monitoring for biologics. Now, general principles for parents. Now, the talking to children about COVID-19 is very important to children. Whether the child is having any disease or not, they should know what is COVID-19 and what are the universal precautions and what are the precautions to be taken if they are specifically immunocompromised or having asthma. Then what other precautions should be taken, that should be thoroughly talked about. That is very important, because the other reasons are stress. Stress is a trigger factor for asthma. So we have to reduce the stress. And reducing stress is just by talking and making them comfortable and telling the facts that asthma will not have risk of COVID-19 or increase the risk, and how to take preventive measures to aware them and give positive environment will help too much. That remaining calm and reassuring, make yourself available to listen and talk. Avoid language that might blame others and listen to stigma and lead to stigma. Pay attention to what children see or hear or television, radio or online. So this is a very important point. And what children see on phone or TV, the unnecessary crap can be shown there. You have to filter it and talk to them. Provide information which is honest and accurate. Teach children everyday action to reduce the spread of germs. Now, factors that may negatively impact children's health when they are staying home from school. Now, lack of access to nutritious or school-provided lunch, mental health issues such as anxiety, depression, domestic violence, child abuse, lack of support services in the community. Now, these are common issues which you may have heard many a times, where discussion for the COVID-19 in children, specifically when they are at home, what are the challenges faced by the children. So these are the topics which you can keep in mind. Now, when returning to school, now we have known about COVID-19, asthma. Now the schools are reopening. Now schools are reopening. It's a tricky situation. As you all know, at this point of time, the pandemic is still on. Still, the COVID-19 transmission has not stopped entirely. Still, there is a risk of third wave. And we are talking about increasing the reopening the school, because that is also a very essential part of the development of child and academics. So by increasing returning to school, there will be increasing exposure. So that is a tricky situation. At this moment in the pandemic, where anxiety generated by misinformation becomes more and more noticeable in families, appropriate information on sensitive topics such as the return to school of children with asthma is important. With chronic respiratory illness in childhood, make this issue a subject of interest to lay the public. Now, this is very important because you can see that despite being school being opened, the children are not going to school. They are still preferring online online lessons or online classes. Now, the importance of school and social interaction is also a very important part of the life or therapy in patients having asthma and reducing the stress by meeting in the friends. But you have to stress upon the facts that how precautions can be taken, how you can go schools and reduce the risk of transmission. That has to be, the topic has to be raised, and it is very important because people like not being vaccinated. They are again not allowing their children to go to school. So in the risk of COVID-19, especially the children with the patient with asthma, they are very worried that the child may get more sick, which is not actually true. So that has to be very clearly explained by taking responsibility by a pediatrician by himself. Now, although the personal and community impact of returning to school is still a controversial issue, there is growing evidence that the asthma and its treatment are not risk factors for increased morbidity and mortality of COVID-19 and may even have a protective role. So this have to be very much clearly conveyed to the parents. In spite of the recent progress, there are still open questions regarding severe acute respiratory syndrome corona 2 infections in school children. Now, found that in absence of other child care options may reduce healthcare labor force, impacting COVID-19 mortality, while Bronner et al. Found that closing schools and university has a large effect on mitigation and suppressing outbreaks of COVID-19. Obviously, when there is no closing the schools and universities will decrease the transmission. But now, when we can reopen, there is a responsibility that now when we reopen, there has to be precautions. There has to be different way. They cannot go back to the normal ways as the older ways. You have to adapt to the newer ways so that you cannot spread the virus. There has to be many checkpoints. Supporting the effect of school reopening in the recent resurgence of cases in United Kingdom being concentrated among school children as well as adults, possibly compromising their caregivers. School reopening and third wave Indian scenario. With many states reopening the schools and many other planning to do so, the looming threat for third wave or unvaccinated children has again become a point of contention across the country. Now the children are not vaccinated. Now we are talking about reopening the schools, and offline attendance have been kept optional and flexible with guidelines for school to adhere to all the COVID protocols. So these questions are not a very straightforward answered questions. It totally depends upon the responsibility of caretaker. It totally depends upon the responsibility of school. It totally depends upon the community where the COVID-19 cases are reported. So it is not a one answer that school should be reopened. It is a mixed type of thing which can be answered by specific things. Now, school reopening and third way, as per WHO, this decision should be driven by data and safety measures must address the concern of student, parent, caregiver, and teacher. A micro-district strategy based on local transmission level, where decision must be taken at a local administration level for opening and closure. So it should not be like from today India should open all the schools. On micro-district level strategy should be made. Now, what micro-district level, what is the situation at that point of time? Whether the COVID-19 cases are there or not, whether the proper education or awareness is there or not, whether proper resources are there or not. But the WHO have proposed the use of following 4 categorization of district depending on local levels and patterns of transmission. So 1 and 2, in category 1 and 2, there's no cases or sporadic cases. There are no transmission level or very few cases, and keep all schools open and implement COVID control measures. In third, if there are cluster transmissions, now there are few groups or few places where transmissions is still there, and keep most school open. Consider closing school in areas witnessing increase in clusters that includes schools. Now, where there is community level transmission, obviously school remains to be closed. So this is a very basic thing that the main thing is that whenever your patient, talking to your patients, you need to think about at a micro district level and the resources and the knowledge or awareness of what the patient or caregiver and the school authority is having, so that you can advise them or make them or provide them a fitness certificate to rejoin the school. Now, asthma care at school. Now, post COVID-19, the asthma and the notes, there are green zone, yellow zone, red zone. Already we have green zones. We know these zones. What are green zone, yellow zone? And green zone is mild, yellow zone is moderate severities, and red zone is severe severities. And these things we know. Now, practicing social distancing. Initially, 6 feet was the social distancing recommended distance in the schools, but in March, CDC have reduced to 3 feet. So in schools, you have to see that the social distancing should be properly maintained, and in small babies, there can be many innovative ideas to implement social distancing and mask appropriate behavior and hygiene behaviors, which we all know very well. So we need to reduce the transmission, and we can go for opening the schools in green zones. The availability of pulse oximeter is very important in schools, though in asthma, in related to asthma patients, if there is asthma exacerbation, the need for pulse oximeter in asthma exacerbation, as you can know that the oxygen saturation goes down late after some time, but clinical problem is very important. Clinical observation or clinical symptoms are very earlier. In COVID, that can be vice versa, that clinically the patient may be receiving fine, but the saturation may go low. So pulse oximeter screening is very important, and it should be trained, and school should take care of that. Now, additional measures, for example, in addition to the broader public health care recommendations, screening, physical distancing, mask, and hand hygiene, specific recommendations might be salient, especially salient for families or children or young people with asthma. For example, regular environmental cleaning is recommended to reduce the presence of severe acute respiratory syndrome coronavirus on surface, and cleaning the product used in schools should be free of organic compounds, irritants, and fragrance. If asthma patients have worked up for the triggers, then it's good that if they know the triggers, then they can uh, 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 take additional measures to uh, keep away from that triggers and sanitize the surface so that those triggers could not become. Additional measures, this is one of the very important measures that you have to open all the windows, or you have to make sure that there is total good ventilation in the classrooms so that proper air ventilation is there in the schools. It should not be in a closed environment, because closed environment is very risky, and this can also be this is also our part as a pediatrician to make school or other people aware about these measures should be taken, not to put on the ACs, rather than just open the windows, open the doors, open the fans, and that might be well enough to uh, give enough amount of um, air exchange so that the COVID-19 can be reduced and asthma patient can be controlled. Special consideration for school and nurses, teachers. School nurses and teachers will need to know which students are at risk in asthma emergencies, and teachers will also need to be responsible for recognizing asthma symptoms. School nurses may need to provide asthma education for children, teachers, and coaches. Now, when at school, students should have easy access to quick relief medications, usually SABA. In the event of asthma flare, by law, students are allowed to carry their own short-acting bronchial dilators. If a student has severe attack, the school nurse may need to develop an emergency plan to the student. Now, September. Now, generally, in September, there is a perfect storm of triggers. Now, we as a pediatrician will be seeing there is a surgence of viral infections and asthma uh, hospitalizations, and increase in V's associated children, increasing in asthma exacerbations. Because in asthma, there is a return to school, the exposure is increased, the allergens, because the children going outside, the allergen exposure will be increased. The normal other viruses like influenza virus and other RSV virus right now are on peak. Maybe irregular medications can be there cause, and anxiety and stress regarding the reopening of school can also be a trigger factor. So asthma peaks, so you have to take control of that. Now at home, for school checklist, you have to have an update of written asthma plan prepared by a doctor. When going to the school, you have to have a written up-to-date asthma plan prepared by a doctor by us. Ensure the child should get back into their asthma routine before the school year starts. Taking preventive medicines every day is prescribed. Having a checkup before the school year ramps up or sport lesson starts to make sure things are going well. Keep or carry medicines at school and keep a peak flow meter. Now these are had to be trained, and at school we have to ensure that there is a comfort. The teachers are having a knowledge about asthma symptoms. They have asthma action plans. They talking to school administrators about possible asthma triggers and receiving training to recognize and respond. And preventive measures should be during the first few weeks of the schools. Can go a long way to helping your child well and out of the year. Now, specific COVID-19 consideration for schools: alternating the schedules or half days, implementing cohorts, selective return of grade levels, one course at a time, one room. These are all guidelines. We all know that initially 10th to 12th was allowed, now from 6th, and the children are allowed. So government is already working on these plans. We have to, as a doctor and as a pediatrician, we have to work upon the education and training purposes to the child and the children caretaker and in the schools. So back to school with asthma and COVID-19, 80% children. Percentage of asthma are caused by viral infection, 50% in adults. Now, back to school mean to return of germs, swapping, dramatic increase in serious asthma attacks like in September. Now, watch for COVID-19 symptoms. Most common fever, cough, shortness of breath, sore throat. Less common fatigue, nasal congestion, diarrhea, abdominal pain, vomiting, chills, headache, due loss. Now, stay on top of asthma. So, follow an asthma action plan. Monitor breathing and peak flow rates. Take asthma and allergy medications consistently, and even when symptom free, you have to teach these things. Minimize environmental triggers. Keep medication refill on hand. These are very important. Keep asthma medication and peak flow meter at schools also. Use a spacer with inhaler to help medication get into lungs. Now, 10 protective tips for COVID-19. Now, we know these things. Wash hands. We should have the technique for before these droplet techniques. Don't touch your face with unwashed hand. Cover your mouth and tissue. Follow physical distancing and stay at home if you have signs of any type of infection. Get vaccinated for childhood illness, flu, and COVID-19 if when comes. Now, concluding remarks, the bottom line for people with asthma during the pandemic is to keep doing what you have been doing all along. So don't worry. Continue taking your controller medicines and inform your health provider of any symptoms that you may develop. Following asthma control plan is crucial. And furthermore, remember to practice social distancing and wash your hands. It is hoped that the pandemic will provide a much needed reset for public schools. Public education has really been redesigned or designed to do things the same way and to minimize risk, not to innovate and solve unsolved problems. It is crucial for students and administrators to think creatively how to bring the technology and the student really relied on the virtual learning into the classroom, how to teach important skills such as problem solving, and how to address not just learning but mental health, nutrition, social, emotional development, and more. So, by this, I'll be concluding my talk. Just we have to think that just continue your treatment with asthma and continue the thing going with COVID-19. Just make sure that you take responsibility to teach parents, to teach caretakers, go to schools and teach them also, and make them responsible also, so that going to school can be really we will seeing the children's going to school, because that is the need for an hour, because social deprivation is not a good thing for every children, especially staying at home is not good. Thank you.
Yes, thank you so much, doctor, for addressing the concerns related to pediatric asthma, and also reiterating the fact that whatever the current asthma medications the child is taking, it needs to be continued and the necessary precautions had to be taken, but also keeping in mind that social interaction is also necessary for the children's overall development. I'm sure multiple doctors in the audience are also facing these queries in their day-to-day practice. So, few of the queries that we have received from our doctors, sir, I would like to ask.
Yeah.
Yeah, one of the doctor has asked, as per the clinical guideline recommendation, short courses of oral corticosteroids are used to effectively treat exacerbations of pediatric asthma. So, for how long would you recommend OCS after exacerbation?
It's not like that. In asthma, when we are treating asthma, then generally OCS are for controllers, as for controlling. If there is a severe exacerbation, if it is very severe or as an admission, then oral, then the things are different. You can give for 5 days to 7 days and then stop it. On an OPD basis, also you can give for 5 days to 7 days till the symptoms are controlled, and then stop it. And don't just continue it giving as a oral corticosteroid. Make them shift and adhere on the technique of ICS, inhaled corticosteroids. There's no need to continue oral corticosteroids for long term, because it is just made for reducing the symptoms. If the patient is very not responding to the measures and having recurrent asthmatic or recurrent episodes, then you may need to reconsider your total asthma treatment plan. That you may need to reconsider that increase the dosing of the LABA, or increasing the dosing of the other medications like montelukast, and you have to see the techniques and reassess the situation, why it is happening, what is the trigger values, what are the environmental things. Because not by controlling just by oral corticosteroids for long term is not the solution, and that's not the right thing.
Actually, on similar lines, I have also received another question that what treatment would you recommend in a pediatric severe asthma patients who has worsened on existing ICS LABA therapy? So, would you recommend that there has to be addition of LAMA, or will you go further and try omalizumab in such kind of cases?
Oh, see, you have to categorize that patient first, whether the patient is in stage, I don't know which year of patient you are talking, but 6 to 12 years, you have to categorize whether the patient is controlled on in stage 3 or stage 4. If the patient is on stage 4, not responding to ICS on highest of the doses, then obviously you must have been added montelukast or leukotriene inhibitors. You can also give chromoglycolate like ipratropium bromide. And if it is not getting controlled, you can use OCS for short term, and again you have to step up for omalizumab. But for that, you have to work up on that, whether it is IgE induced or not IgE induced. For that, you have to, and also you have to take care of the trigger factors also. Many a times there are continuous trigger factors in the home in perennial situations, like house dust, cockroaches, house dust mite, or cat danders, which are the trigger factors which we don't care about, and we just treat on increasing on medications. So we have the avoidance of allergens is also a equally important part. We have to focus on that also. If after that also it is not working, then obviously after ICS or OCS, and if there is an acute exacerbation, there should be an admission. And if it is not an acute exacerbation, then you may might consider for omalizumab or other biologics.
Okay, yeah, that's a very good point that you have made, sir. That we, apart from we just don't need to focus on the addition of medication, but we also need to focus on the taking care of the trigger factors part. So yeah, so the next question also actually pertains to allergic rhinitis and coexistent asthma. So do you think allergic rhinitis and coexistent asthma is a risk factor for severe form of COVID-19 in pediatric age group? And if so, would you recommend allergen immunotherapy in children who are at such kind of a high risk case?
See, first of all, allergic rhinitis and asthma both can coexist, and they do coexist in most of the cases. And in consideration with allergic rhinitis and asthma, in both have Th2 response system if it is immune as per immune pathology. That will, as per the pathology or pathophysiology, which till now the studies have suggested that the patient with coexisting COVID-19 will not have increased risk of getting into severe ARDS. So this is one thing. So allergic rhinitis and will not change the course of COVID-19, because the basic pathophysiology behind allergic rhinitis and asthma is the same. So that can be applicable with both the pathophysiology of COVID-19 and the asthma. If combined, the studies have said that there can be less risk, even less risk, but it will not increase the risk. The other part what was the other part of the question?
So would you recommend allergen immunotherapy in children who are at higher risk?
So yes, high risk, I don't know what does he exactly mean about the high risk. high risk if the patient is on immunotherapy and or oral corticosteroids. I'm sorry, oral corticosteroids or at that point of time, we don't start immunotherapy. We first control the patient. For that, we have to have a specific trigger trigger identification, because immunotherapy is done after isolation of the triggers. If there is a specific trigger which is the main problem, and you get on the control, you get on knowing about the specific trigger of the patient, then oral immunotherapy or YT or skit can be done after getting on controllers. And when the patient is stable, then you can continue with the immunotherapy. But immunotherapy is one thing which you should know, that it should not be used very uh, because still now the data are not very solid about the immunotherapy. For that, you have to have a very strong evidence upon specific trigger and specific allergens. And when you have a specific allergens, then you can treat the patient when they are on a control phase. So high risk patient, I don't know. High risk patient, the patient who are on a high dose of oral corticosteroids can be high risk if they are not uncontrolled uh, asthma. That can be a high risk. So if that kind of situation, then obviously the immunotherapy is not indicated at that point of time.
Okay. So next question is, once schools open up, which therapeutic approach should be adopted in the first 3 to 6 months, especially in case of for mild to moderate pediatric asthma patients? Like whether it should be a step up or step down approach, or whether it would depend on the season.
So uh, I can divide this into two parts. First part, if you know the uh, triggers or allergens, then you can act accordingly as per the allergens. And you can step up if there is the allergens or the seasonal pollen grains, or the according to the season, if the pollen grains are or pollen or indoor allergens are increased, you can step up things. But if you don't know the specific triggers or specific allergens, then better to step up the uh, uh, controllers, so that, because when the child will go out, it will be like pollution, dust, other exposures to other allergens, which we don't know what is the triggering point of the patient. So that the risk of exposure will increase. So by increasing the controller dose for 1 or 2 months or 3 months and monitoring that, and after that we see that it is fine, you can decrease it. Yes, I do agree with your the theory that we can increase the controller therapy for first 1 or 2 months or 3 months, and then we should decrease it as per the situation or as per the season. If you can find out the triggers.
Okay, okay. And the next question is, when children return to school, there will be higher chances of infection with rhinovirus and respiratory syncytial virus. So, how to manage such kind of a situation? Any additional precautions that need to be exercised by the parent?
So just go previous to the pre-COVID era. In pre-COVID era, the situation was same, and all the asthma children were going schools. They brought viral infections like RSVs or adenovirus or influenza viruses. Coronavirus was still there at that time, not COVID-2. So at that time also the viruses was there, and when there was URTI, there were exacerbations. So we had to step up the controller therapies and give short term SABA or kind of relievers. So that was the standard treatment, and still it gonna be the same. It will not change after the COVID outbreak. Also, you just need to take extra precautions for COVID, and by taking extra precautions for COVID, you might see that there will be reduced transmission of other viruses also, because you are already taking precaution which was not taken back pre-COVID era. So you'll see that there will be less exacerbations due to viral infections if you are taking precautions right.
Right. So, one last question, sir. With limited options and access to school canteen amid current COVID pandemic situation, what could be the best dietary advice to parents for parents of pediatric asthma patients?
See, there is nothing to be changed. In fact, we have to, because there are two things. If the child is having food allergies, or the child, you know that the child is having food allergies, then obviously whether child is going to school, you have to inform the school that the child is having specific type of food allergy, and this type of food cannot be given to the child. For generalized measure, there is nothing specific to be done specifically for asthma patients, because if as per because there is no specific trigger or any specific protein like cow milk or wheat or nuts or these things. If there are in schools, the meals are going on as before it was going on. There was no difference then. Now also it will be, there's no difference will be there. In general, you cannot generalize a specific diet for an allergic patient. For in generality, if for a specific patient, you can make a specific diet if you know the triggers, or if you can control by eliminating some food particles from the specific diet of the child. Or in general, you cannot apply out in general. For specific patients, you need to make a specific action plan of asthma in that, which contains a trigger control system. In that, if there is a food allergy, induced asthma, or food allergy is something, then you need to get that thing noticed to the school administration, so that that particular child should not be given that particular food item, and that should be taken care of. But you cannot do that in general.
Right. So basically, we need to identify the trigger factors and continue the preventive measures that we were taking. So thank you so much, sir. You have actually covered this topic quite extensively, and the Q&A section has also brought much more clarity to the audience. So I would like to extend gratitude on behalf of Lupin Limited for enlightening our audience with a very interesting take on managing pediatric asthma amidst COVID-19. Thank you, sir, and thank you to all the attendees.
Thank you so much.
Recording stopped.